Good afternoon, everybody. Okay, let me share my PowerPoint presentation. Okay, there are certain terms which is connected with end of life care. So we will see. So you can see end of life or a patient who is terminally ill or terminal care period. This duration can vary from months to days. Okay, but you can also see that when the patient is actively dying, it is we say it is in days. Uh, okay, we are talking about patients who has maybe weeks to days, but generally end of life, a terminal care or actively dying patients all are included in end of life care. So before moving on to end of life care, have you ever thought of your end of life? Any of you have thought of this? You are so young and you are asking us. Any of you have thought about it? Nobody? Okay. Um, okay. At least I have thought about end of life, but we don't know when our death is going to come, isn't it? So, is end of life important for you? Anybody? What do you think? Is it an important uh, thing for you? What do you think? I'm not talking about your end of life, but think about somebody who is close to your heart. And do you think the end of life is important? Okay, Dr. Hari Babu says yes, end of life should be peaceful, pain-free. Okay, thank you, Dr. Hari Babu. So, I'm going to ask another question. If it is important, who are the people for whom it is important? Suppose the patient is in a hospital. Who are the parties? It is very important. It is important for the patient, isn't it? Because as Dr. Hari told, it is important in many ways. And many patients might think of how uh, how the death is going to occur to me. Will I be breathless? Will I be in pain? Or is there any other things that is going to occur me? So it is important from the patient point of view. Is it important for the family? What do you think? Any of you have seen or had death of any family members in your family? Any of your relatives died, and you remember about how they died? Nobody has seen a patient is dying in your family or your relatives or neighbors. If you have seen a patient,
Hello.
yes, Kumar will.
I have seen one of my friend.
Sir, you're not audible, sir.
Hello.
Yes, yes, Kumar will.
Hello. Hello.
Yes,
Am I? Yes, am I audible? Yes.
you are audible. Yeah.
Yes, sir. Actually, I was in one of my friend.
Ah.
He has massive heart attack at the age of 42. So when we are out of that is our working station is in somewhere. So when we are out of place, he has a massive heart attack, and within I think 2 hours or 3 hours. So there one of the doctor tried his best. Then he expired after that. So that is the first experience with there is patient who is dying. There is end of life.
Okay.
So later on in hospital setup, I have seen some of the patients. So those who are in end of life. And, so that is my experience with the patients.
So from a family's point of view, how should the how should their relative die? What do you think? From the family's perspective.
Family perspective.
Yeah.
It is very difficult moment. A very difficult moment to experience.
Yeah.
Those who lived with us.
Yeah.
And that is when they are not there. Then it is difficult to feel the sensation.
Yes. So any others remember about the death of their relatives or somebody who is close to your heart?
Hello, sir, I'm
yes.
not getting this.
Now I am asking about other than Kumar well, has any other participants have seen the death of a relative or neighbor? I am asking because it is important from the family perspective how the patient is dying, isn't it? So your friend died suddenly. He had a massive heart attack, but this occurs in rare situation. Most of us are going to have a very probably going to have a lingering death. Probably going to be bedridden for some time and then going to die. But the patient dying acutely, that happens to very lucky people only. So most of us will not have that luck. So when the family look back about death of the patient, what do they remember? After a week or a month or after a year, when the family member look back, what do they remember about the death of this patient? Anybody?
Sir, Smisha Parikar was about to ask you something, sir.
Yeah.
Smisha, can you hear me?
Yes, sir.
Yeah, you can.
No, sir, when you said about, hello, can you hear me, sir?
Yes, yes.
Hello. Yeah. No, sir, it was regarding.
Your voice is breaking.
Yes, that's all. I think it's network issues. Hello.
Your
Hello.
voice is breaking, Nisha.
Sir, I think the network issue, sir. Sir cannot.
So it's okay, Smisha. You can put it on the chat box so that we can read it. Actually, we are not able to hear you properly.
Okay, sir.
Thank you, Smisha.
So, when we look back as a family member, we are going to remember how our close one died. Has he died comfortably, or was he in severe breathlessness? Was he in pain? Was he in agitation? So all those things are going to come to our mind when we look back about the death of our close one. So it is important for the family also, but it is equally important for health professionals, because when we manage a patient's death or end of life in a good way, then the doctor or the health professionals, that is including nurses, doctors, physiotherapists, social workers, everybody will be comfortable, because they know that they have managed the end of life well, and the patient was able to leave this world comfortably. So it is important for all these three group of people, and all of us know that if this is the primary thing which we need to understand. We will not be able to cure all the people. We can cure sometime. We will be able to relieve their problems often, but it's our duty to comfort always. So in case of end of life care also, it is our duty to give a comfortable death for the patient. So there are two situations you can see. One patient is at home, surrounded by the caregivers, her loved ones, and the other in ICU. So if I ask you to choose one for yourself, which one will you select?
Of course, the first one.
Who was that?
Abhilash, sir.
Abhilash.
Sir, my name is Abhilash.
Yeah, Abhilash. Thank you. Can you tell me why did you select the first one?
Because we know in the hospital step how pain he or she has to tolerate at the time. So I just want to avoid that things. That's why it's my personal choice only.
Yeah, but I think everybody can vote which situation will you select for yourself if you are going to die. The first one at home and second one at hospital. I request everybody to call your vote in the chat. Please type your option in the chat box.
Sir, actually, Smita Mata said it's first one. Mr. Kumar.
Yeah, I can see name for Priyadarshini. All have selected first one. So what does that indicate? Many of you might be working in multi-specialty hospitals, and when we are sure that we are going to die, and there is nothing else that is going to save us. In such situation, we would like to have the first choice. But what happens to many of the patients? Just think about it and reflect on that. So all of us want the first situation when death is sure, isn't it? But if the life is salvageable, in such situation, definitely the patient has to be in ICU, because after some time the patient can come back with good health. But in case of unsalvageable life, then we all want the first one, isn't it? So we would like to die at home. There may be some differences, but I think many will select the first choice. So is it something called good death? What's your opinion? Is there a good death and a bad death? So I would say there is something called good death. So there are some components for good death. So what are the components? So there are many. I'm putting here only 6 points, but there are many other points which will come into your mind. But basically, the patient should be comfortable, isn't it? The person who is going to die should die peacefully. He should be symptom free. He should not have pain, or he should not have breathlessness. So the symptoms should be properly managed. So this is one aspect in which many patients are afraid to die, because they think when they are going to die, they will have pain, breathlessness, nausea, vomiting, or even seizures. So it is very important to have very good control of symptoms. And there should be clear decision making. So whenever we are planning that this patient is going to die, and when we plan about death care and death and its management, we should include the patient so that they will have reduced anxiety. Suppose the patient thinks that I will be in severe pain, and he is included in the decision making process, so that the doctor or the health care team can tell him that we will give medication to relieve your pain, and that's an assurance that we can give you, or we will be able to reduce your breathlessness. So all those things, the patient should be a part of it, so that the anxiety of the patient can be reduced, and the patient will feel more comfortable. And when patient is also a part of the discussion on death, many patients will understand, or they will have many doubts. How is it going to occur? What would be the process of dying? And if this occurs to me, what are our plans, etc. So that's another aspect. Then we have to complete the or we should allow healing of the person in the spiritual aspect, and we should also ask the patient to come up with his story, that is known as life review. We will ask him about where did you born and brought up, and how was your life till this moment, and we are going to reinforce his achievements. so that the person will feel that he has a value. And saying goodbye, spending time with family, all these are important aspect of good death. And you can see some people when they are near end of life, they will give gifts to others, or they will sometimes it will be an advice. So these are something which they contribute to others' well-being, and that's also important part of good death. And we have to see the person as a whole person, not as a person with disease. Uh, when the medical personnel see the patient as a person with a disease only, they will see only disease, not seeing him as a person. So it is important to see the patient as a whole person who has his own values, his own meanings to the life, etc. So these are a few components of good death. So in order to assure good death, we should follow these principles. And why should we talk about end of life care? You can see this graph, and this is a survey by Economist Intelligence Unit in 2015 among some 77 countries. And you can see the quality of death in India is India ranks at 67th position. So that means India is a bad country to die because quality of death is very low, and they have considered these 5 factors, whether there is a good healthcare environment and palliative care environment, and what are the human resources available, and is the care affordable to people, and what is the quality of care provided to the patients, and is there a community engagement. So these are the points which they have considered to come to this ranking, and India's position is very low at 67th position. So it is important for us to make this situation better. Otherwise, when we are going to die, our situation will also be like this. So what should be the process of end of life care? So when we, from the symptoms and signs, we should understand that this patient is terminal. And if you are working with a team, then there should be consensus with the team, the doctor, the nurse, physiotherapist, social worker. So all of them should have one answer that this patient is dying. Otherwise, somebody will tell that this patient is dying. Somebody will tell that no, this patient is not dying. So the goals of care will be changed. Somebody will treat aggressively. You may give aggressive physiotherapy for this patient, thinking that okay, this patient is not dying, but the doctor may think that okay, this patient is going to die. So it is important to have a team consensus. And once the team have a common consensus, then it should be communicated with the family and if possible with the patient also. Then we will document this thoroughly in the case sheet, and we have to discuss with the patient and family what are their expectations about end of life. Then there will be consensus with the family and treating team. Then provide end of life care. Once the patient dies, we have to provide that care. And even after death of the patient, we have to provide bereavement support. So as you know that palliative care extends beyond death of the patient as bereavement support for the family. So let's see what are the symptoms and signs suggestive of patient is terminal. Can anybody tell me that what are the symptoms and signs when the patient is near end of life or patient is going to die? What would be the signs and symptoms? Anybody?
The patient will be bedridden.
Yeah. Patient will be bedridden.
Difficulty in breathing.
Yes, difficulty in breathing.
Pressure may fluctuate.
What fluctuate?
So BP, blood pressure.
Yeah, okay. Blood pressure will fluctuate.
Unable to speak or
yes. Anger and refuse to accept. Okay. So let's see what are the signs and symptoms. So the patient will be either semi-comatose, semi-conscious or comatose. So the conscious level will be reduced, isn't it? And they will be unable to take anything orally. Probably they will have drops of water, but they will not be able to take any medications. And as you told, the patient will be confined to bed, bedridden. And they will not take any food or fluid. They will lose the interest in food and fluid. Then the patient will be detached from the surroundings. The patient may not recognize you or even understand that there are people surrounding him. And failing vital signs, that is, there will be tachycardia, the blood pressure will be low, respiration, the rhythm will be abnormal, and they will not respond to your questions. So there are many other signs like incontinence of bowel and bladder, cyanosis, many things. But these are few signs and symptoms by which you can understand that patient is going to die. And if at least 4 of this are there, you can say that patient is actually dying. Okay. So I told you that once the team have a consensus that patient is going to die, then we should have a discussion with the family on expectations. On expectation, what do they expect when the patient is going to die? And if possible, we should also discuss this with the patient. So I don't know how many of you have thought about this. The place of care of death is very important. None of you have thought about your death. So I'm not sure whether you understand it is important that the place of care is important for the dying person. So we should discuss this with the family or with the patient also. Does the patient have expressed whether he need to die at home? So when you have a home, you will have attachment to that home, and it's a particular feeling that all of us will have, and many of us might also think that when I am going to die, I should die in that particular room of my house. So we should respect that, and we should stress the importance for symptom control. The patient should not be breathless, patient should be should not be in pain, etc. And we also will tell that many of the caregivers will tell you that do all the possible things, even including ICU care, even artificial ventilation. So we have to talk to the patient and family and make them understand that these interventions are not going to help at this moment of life. So it is very important for us to discuss with the family and make them understand. And they will have many questions. We have to answer those questions also. And many patients might have unfinished things, maybe writing a will or something like that. So we have to facilitate to finish those unfinished business. And there will be rituals or religious last rites which we should be able to facilitate. And we should also ask the family whether this patient has expressed any wishes, and if possible, we should be able to facilitate or close that wishes. So What do you think? Do we need to talk about that to a person who is going to die within a few days or weeks? Anybody? Okay, let me show you a video. Anybody? In this video, the doctor has explained how to communicate regarding that. You can see that the patient asked how long I have, and the doctor told that it is very difficult to tell, but um, it seems that you have days or weeks. We will not or will not be able to give a date, and it should not be done. We will give some time frame like days or weeks, depending on the health of the patient. So um, that's one thing, and there are many other things they have talked. The patient asked how that is going to happen and what will happen to her. And she also asked about gurgling sound in her throat. Uh, there are many things, and she wanted to write a letter to the daughter or child of her daughter. And the doctor actually reinforced the good things that she has done, uh, and that she will feel valued or valued. Uh, so there are many things that has happened in this video, or the doctor has brought about. Okay, so what are the important points that we need to be careful when we talk about that? We should be open and genuine. We should not lie to the patient. If somebody is going to die and if they ask, am I going to die? We should not lie them. Okay. And actually the patient should lead the interview. So encourage them to talk. So you can see that in this video, the doctor has actually encouraged the patient to talk, and most of the talking was done by the patient itself. And it is very important to understand the concerns of the patient. You can see that the doctor was asking, are there any other concerns for you? So we have to explore the concern. And whatever be the circumstances, we need to be empathetic. And I already told you that when this type of question is asked by a patient, how to deal with this. And we know that we cannot predict the death certainly. So we have to tell that it is uncertain. And the doctor has actually done a life review of this patient. He brought about the important points or the important things that the patient has done in her life. And and already told you that this is a part of life review, that they have lived a very good life and they have a lot of achievements, etc. So that the patient will feel valued. So that's the most important thing. The patient should feel valued. Okay. So now I am going to talk about a few symptoms that usually occur during end of life. So pain, breathlessness, delirium, and death rattle. These are a few common symptoms which may occur at the end of life. James, do we have a case discussion for this session?
No, sir. Actually, we haven't got a case discussion, sir.
Okay. So this is a doubt which many caregivers have. Do we need to actually continue the previous pain medication when the patient is dying? What's your opinion? Anybody? So actually, we have to continue with pain medication because if the patient was on analgesic previously, it was for some pathology. If that pathology was not reversed, it is still there. So it is going to cause problem or pain for the patient. So we have to continue with the pain medication, maybe with maybe some reduction in dosage, maybe 1/3 of the dosage can be reduced. And you might have seen or might have heard about delirium. So these are delirium is an acute confusional state in which patient may talk irrelevantly and they may be agitated. They may be using abusive language, etc. So delirium, when the patient is going to die, up to 88% of patients can have this problem, delirium. Okay. It usually occurs in the last hours of life and days in these patients. So whenever a patient who has a terminal disease, and if they come to you or when you see a patient, you are doing physiotherapy and you know that this patient is deteriorating, and if he talks irrelevantly to you and he has altered consciousness, you have to think whether this patient is going to die. That's a terminal delirium is an indication that this patient is going to die, and this is due to end stage organ failure, and this is not usually reversible. So you will not be able to reverse it, but you will be able to control this with medications. So it is very distressing for the patient, for the family members to see this, and healthcare professionals also it is distressing because they will not be able to communicate anything to the patient. So you might have seen patients are tied to the bed in hospitals because of delirium or agitation. So it should not be done. There should not be any mechanical restraints. You should give medication to reduce the agitation. That's what we should do when patients has delirium. Okay. This is another thing which the previous video the patient was talking about, gurgling sound when they breathe. Any of you have seen this death rattle in patients? Anybody? Okay. So this is the noise produced by the oscillatory movement of secretions in the upper airways when the patient breathes. Okay, so with inspiration and expiration, there will be gurgling sound usually. This is because the salivary secretions will get collected in the throat, and when the air moves through it, it will produce the peculiar sound, which is known as death rattle. So what can be done for this? So this is very distressing for the family, but this is not distressing for the patient, because if the patient has death rattle, probably they will be unconscious. So patient will not be knowing anything, but the family is the family will have distress to hear this sound. So how can we manage this? We can manage either non-pharmacologically or pharmacologically. What is the non-pharmacological explanation? We have to explain to the family that the patient is unaware of this because the patient is unconscious, and it is because of patient is unable to swallow the secretions. And you can actually keep the patient in a recovery position, either left lateral or right lateral position. so that the secretions will drain out according to the gravity. Or you can use a gauze which is wet with normal saline, and you can take out the secretions with the handle of the this gauze should wound around the handle of the spoon, and that can be used to remove the secretions. And if this is not relieving the problem, then you should think of pharmacological management. There are some medications which can be used to reduce this death rate. So I am bringing about a patient story. This is a patient, Mrs. X, 60-year-old woman, is diagnosed with advanced cancer of the stomach. She is in her last week of life. Her appetite is very less and not eating much. Family is compelling the patient to take food. Patient says, I don't have much appetite, and the family is compelling me. As she is not taking much food, family want us to put a feeding tube. What should we do? This is a very common situation that happens in hospital. So you might have seen this. What will you do in such situation? Anybody? So what's your opinion about this? Should we put a feeding tube, that is rice tube, for this patient to feed? Yes or no?
Spoon feeding can be done.
Spoon feeding. Okay. Thank you. Kumar bhai, what is your opinion? Do we need to put a rice tube?
You can put trials tubes.
That is Tamla Resi says we can put rice tube. Yeah. Anybody else? So I would like to ask Tamla Resi, why do you want to rice tube for this patient?
So then only we can, whatever medications they are giving, then only it will help for the patient. Sir. If she is not nourished well, then no, that won't help for her survival.
Okay. Thank you. Somebody told that spoon feeding can be done. So can that person talk about why she select spoon feeding?
Rajalakshmi,
The patient doesn't feel.
Yeah. Please talk.
Not having appetite.
Yeah.
So if we give feeding tube and all, it will be difficult for the patient for swallowing and all.
Okay, let's see what we have to do in this patient. So just understand that this patient is in her last week of life. So only 1 week to die, or maybe even die within a day. We don't know. Okay. For food intake also, in palliative care, we talk about physical, psychological, social, financial, and spiritual aspects. For food intake also, there are 4 aspects. From the physical point of view, why are we taking food? It is for us to get energy, isn't it? So we will eat, we are eating many things. It is to get energy. From the psychological point of view, suppose when you go to a hotel and you see that the other person is having an ice cream, we will also try to get an ice cream, isn't it? It is from a psychological point of view. And from the social point of view, whenever you go to a house at Kerala, they will give you tea. That is the social aspect of food intake. And from the spiritual point of view, when you go to temple or church, they will be giving offerings. So that's from the spiritual aspect of food intake. So food intake has all these aspects. And what are the when you say that we have to put rice tube, or we need not put rice tube, we have to look at the advantages and disadvantages of putting a rice tube. So what are the disadvantages, or what are the problems that can occur with a rice tube? So if, or from a compulsive food intake, as I told you, the caregivers will compel the patient to take more and more food. So what does it is going to cause? From a physical point of view, it can cause vomiting. So if we don't like any food, then we are going to definitely going to vomit, and we will feel breathless, and this patient has pain, sorry, carcinoma of the stomach, so it is going to cause more pain. And from psychological point of view, the patient will think that till now all the family members obeyed me, but now when I have a disease which is very advanced, nobody is obeying me. That is going to cause either angriness with the patient, or patient will be worried or sad. And from the social point of view, the patient will think that I have lost my status in the family. Nobody is obeying me. And from the spiritual point of view, the patient will think that nobody is understanding me. I have loss of appetite. I have a very advanced disease, but still, that's the reason why I am not taking food. But this, nobody is understanding that. So these are the disadvantages or side effects of compulsive food intake. Or even the patient may aspirate when you compulsively feed the patient. Okay. So is it going to do any good for the patient, the compulsive feeding? So you can see this is a plant parasite. Any of you have seen this plant parasite? In Malayalam, we say it is Ittilkanni. I don't know what do you tell for this particular plant parasite. Have you seen? Any of you have seen this?
Yes, sir. Yes.
Okay. So take this patient whom we are discussing. This patient has a very advanced cancer, isn't it? So the cancer is like a parasite in our body. So suppose our body is this tree, and the parasite is the cancer. And when the patient has cancer at first, that is not going to cause much problem to the patient. But after a period, what happens? We will be cachectic, isn't it? Like this, after some time, what happens? The tree will be die, or the plant parasite will grow. That's how the cancer in our body. So as the cancer advances, we will be cachectic, but the cancer will be spreading throughout our body. So this is a scenario which you can talk to the caregiver, and make them understand that at the last stage when the tree is dead or it lost all its greenery, leaves, etc. When you give some manure, it is not going to benefit the plant. Uh, the plant is anyways going to die. That's what happens to a patient with advanced cancer. And this is another explanation what happens in our body. When we are child, we will have milk, breast milk, etc. And after some time, maybe at the age of 5, 6, we will have a little bit of food. But when we are adolescent, then we will have a plate full of food. And then after the age of 50, the food will decrease. It will continue to decrease. And when we are bedridden, we will have a glass of water. And it is after some time, it is again going to decrease. It will be, you will be taking only a teaspoonful of water, and at last drops of water. And then there will be a situation where you need not want any food or fluid, and at that stage you will not also need any oxygen, and that is the situation when the patient dies. So this is a physiological process which occurs to each person. So this patient also has gone through all this stage. Now they have come to a stage where the body doesn't want any food or fluid. The body is rejecting it. And even if you compulsively feed, your body is not going to absorb. Your cells are not going to utilize it. Okay. So if you look at this patient, if you compulsively feed the patient, it is not going to be any beneficial for the patient, but rather it is going to cause more harm to the patient. So it is not advisable to put a rice tube when the patient is dying. If we want to, and even we need to think of medications. All the medications we need not continue. We need to continue only those medications which will give comfort for the patient. There will be a lot of medication, at least 10 to 15 medication for a patient. There will be atorvastatin for cholesterol, aspirin for to reduce the blood flows, etc. There will be many, and there will be many vitamin tablets. All these are unnecessary at this stage of life. So we have to actually stop most of the medication and continue the medication which will give comfort to the patient. And many of the medication we will not be able to provide through mouth. Then probably we have to put it in the rectum, or we have to give it through injection. Okay. So the other question then the caregiver will ask you is that if we are not feeding, how is he going to live? That would be another important question asked by the caregiver. So what would be our answer? We as normal people, we need energy, isn't it? For that, we have to take as much as food possible, because we are playing, we are thinking, we are running, walking, etc. But the person who is dying, he is not doing anything. He is just lying down, and his internal organs need to work, and that energy will be provided by the food what he is taking. He might be taking little bit of water, little bit of tea, etc. And that is enough for the internal organs to work. And if you compulsively feed him, it is not going to utilize by the body. So if body is not going to utilize, why should we compulsively feed the patient? That's the question. So we have to actually weigh the risk of a compulsive food intake along with benefit. And we can see that if you compulsively feed the patient, the risk will be more. So it is not advisable to compulsively feed the patient. But at the same time, we have to understand the feeling of the caregiver. The caregiver is eating, but their loved one is not eating anything. So we have to actually empathize with the caregiver and make them understand that the force feeding or compulsive feeding is not going to do any good for the patient, and ask them to give whatever the patient wants to eat at whatever be the quantity and whatever be the frequency. Okay. I already told you that we need to continue medication. Actually, we need not to continue all the medication. Continue the medication, which is going to give comfort for the patient. And we need to avoid. I don't think we need any investigations for a patient who is going to die. So we will not do any investigations. And actually, the physiotherapy, aggressive physiotherapy, need to be stopped at the stage, because it is not going to do any good for the patient when he is dying. And I will show you another video, and I will end with that.
End of life care.
So, any of you have any comments regarding this video or any doubts? So the most important thing in end of life care is provide a comfortable death for the patient, so that when the family think back, they will also feel that their loved one departed this world without much suffering, so that actually the family will remember you, that person, that doctor or a nurse or a physiotherapist who made this process very comfortable for us. So it is very important that the end of life should be managed very meticulously and very carefully, so that patient will have a dignified death. So thank you. And if you have any doubts.
Thank you, sir. Thank you very much for that wonderful and heart-touching session. It was very informative and to understand the importance of medical professionals in end of life care. So now I think it's time for the discussion. We have around 7 to 10 minutes for discussions, and I request our participants to ask your doubts or put your comments in chat box, so you can unmute yourself and speak in. Or if you have any experience regarding this end of life care or something, that also you can share with us.
Anybody?
Sir, it was a wonderful presentation, sir. Actually, we have no idea about these things, especially the end of the life care. So you cleared almost all the doubts. And there was no idea. That's frankly I'm saying, there was no idea about the end of life care. You changed the total concept of end of life care, sir. Thank you very much.
Yeah. What I would like to tell you is that nowadays we are having more of nuclear families, and we are not allowed to see the death of the loved ones. And if there are children, most probably the patient is going to die in the hospital, and nobody is seeing what is happening. It occurs in ICU, isn't it? And we don't know what the patient is going through. And when we understand these things, then only we will be aware of what is going to happen to us, and how should we plan for our death. Even though it will be cruel to ask you to plan your death, but this is we have to actually be aware of this situation. And actually, the hospitals are seen a place of where the life is saved, and patient is not being allowed to die, isn't it? Patient should not die. If the patient dies, that hospital is not good. That's the notion.
Thank you, Ablash. Thank you for your valuable comments on class. Would anyone else to comment on the session or have any doubts or anything for discussion? If not, we can wind up the meeting, I think so.
Okay, James. Thank you all for your patient hearing.
Thank you, sir. Thank you once again for that wonderful session.